So thank you to all the panelists. We are now going to move on to questions. And please remember to submit a question using the following icon, and we'll be going through them. So we'll start off with one question to Dr. McLaughlin, and certainly, you know, the early life adversities can be so impactful. So what can be done to intervene early, or what can we do as members of society or as scientists, researchers, to reduce disparities early on?
Yeah, it's a great question, and I'm glad that you ask it because there's an enormous amount we've learned about factors that can prevent these negative long-term health consequences associated with early life adversity. You know, some of those factors exist sort of at the family level. We've learned, you know, in study after study, even studies that we've done that are looking at the biological imprint of early life adversity on the brain, that the presence of social support in a child's life, in many cases, this can be the presence of just a single adult who is invested emotionally in that child's well-being, can have an enormously powerful protective effect against these long-term biological consequences and even health consequences decades later. We know, similar to what Dr. Hackman shared in the previous panel, that supportive school environments, we're increasingly learning, can help to mitigate some of these long-term negative effects of early life adversity. But I also want to emphasize that we're learning more and more about how the broader social context that children are embedded in can not only confer risk, but also resilience in the face of adversity. So similar to the discussion at the end of the first panel about the long-term imprint of structural racism and stigma, my colleague Mark Hatzenbuehler here at Harvard and I recently published a paper showing that growing up in a context that is more structurally stigmatizing towards a member of your group or an identity that you hold, whether it's race, ethnicity, sexual orientation, can leave an imprint that we can measure in the brain in terms of things like the size of the hippocampus and other meaningful aspects of brain development that are associated with many of these long-term central nervous system diseases that have been the focus of these discussions. But on the flip side, what we know is that if you're a child who's growing up in a social context that's more supportive towards your identity, and there are many states and contexts in this country that do have those more supportive social contexts, that you see not only a reduction in risk, but that those contexts can actually protect you against these individual sources of stress and adversity that are so common for children from historically marginalized backgrounds. The final thing I'll say, I don't want to take all of our time, is just that this more recent policy work really suggests that, at the end of the last discussion, there's this sort of question about what do we do about these structural factors that can be so hard to change. And there are levers that we can pull at the policy level that have widespread effects, not just on one child or family, but in enormous communities within this country. And that is a lever that I think as scientists we need to be paying more attention to understand how changes in policy can lead to improvements in health in many, many different ways. And the more work we do on those types of structural factors that can provide support, the more able we'll be to develop the kinds of policy solutions that really can have an impact at the population level.
Thank you. That is certainly, I cannot agree more with some of the, things that we could do, and certainly going all the way to policy. We come back to policy. And so Dr. Manson, certainly, working with Native communities and the different types of communities in which they live, either just rural or reservation, is there some cultural factors perhaps, or cultural or community-based resilient type of factors that you've seen or work that you're trying to do with the local or at the regional or state or federal level that could be important to addressing some of the barriers that they do have?
Of course. Let me comment on it from two different perspectives. The first is our work with American and Alaska Native communities has been driven not only by the importance of health equity and social justice, but also diversifying the scientific workforce and our understanding of the kinds of underlying constructs that are critical to understanding and intervening with respect to CNS. For example, there are a number of illustrations in which work of this nature, community engaged or community-based participatory research, actually improves our science. We've been able to discover important key constructs that had not been previously anticipated by many of our theoretical frameworks. Notions of community mindedness. Now, for example, we talk of it in terms of social connectedness. Matters of engagement and recruitment into trials, such as Dr. Mendoza and Mr. Strum underscored, but it's more than increasing the representation of Native people in these trials for purposes of anticipating and accommodating the variation in their lived experience and what that may imply for the nature of risk protection and recovery from CNS. But it also has to do with the increased ability to interpret and understand the nature of the phenomena that we're examining, and ultimately getting back to the very tenets of predictability and consistency from the point of view of scientific methods. So it's incorporating these kinds of community partners, not simply as a matter of equity and social justice, but to actually assist us in improving the science in those kinds of ways. We do hold different kinds of explanatory models for understanding these kinds of conditions. Those explanatory models suggest new important constructs that we should attend to, both in terms of our science as well as preventive and clinical care. So there are a number of examples coming from not just Native communities, but others as well, that can improve science as well as the nature of care that our people deserve.
Thank you. Thank you very much for sharing that. And I guess piggybacking on some of what you just mentioned about, how do we get, diversity into studies, clinical trials, and perhaps, John, you have, were you able to work on some of that through your Real Talk MS, certainly even with vaccinations at one point, perhaps some of the barriers or facilitators you might have identified within the community? Could you share with us?
Absolutely. I have found that what's been particularly effective through my podcast is bringing on thought leaders from underserved communities who can speak directly to the barriers they face every day, and in many cases dispel some of the false information that's sometimes too closely held. That's been a very effective way. I have been told by clinical trial principal investigators that after these kinds of conversations have been circulated for a week or two, they've seen an uptick in recruitment. So we get to measure the actual outcome of doing this kind of outreach and seeing it done effectively. The other thing that's made a key difference is being able to create strategic partnerships with other patient advocacy organizations who can extend the messaging and extend the reach of those initial conversations. All of that has worked to build an audience that frankly would have been much more difficult to build all by myself.
Thank you. Thank you for sharing that. And I think so certainly the reach, the identification of other leaders out in the community can certainly help us reach what we want to do with our, affecting whatever health outcome we have of interest in working together. So not just working together, but developing those relationships, understanding their needs, and so important. And I guess, there's certainly challenges out there to implementing any type of culturally developed type of intervention. Any of one in the panelists, do you want to share some of the key challenges, I guess, you see with implementing culturally based engage, sort of interventions, meaning do we need to do it specifically for one culture versus another or within groups? I know Dr. Monica Rivera Mint mentioned, obviously, there's heterogeneity within groups. So do we need to built one for Puerto Ricans versus one for Mexican Americans. What are your thoughts on that?
I'll jump in here and thank you for that that question. I think that one of the key challenges when we think about culturally informed, community engaged research is that even when we're doing national work, in many ways the work occurs in a very local context, right, for each of us. And in those local contexts, we need to know our populations, because I don't think we need to tailor something for all people at all places for one academic medical center per se. Here in Harlem, for instance, we're more likely to see Afro-Caribbeans, for instance, right? Individuals from, Puerto Rico, Caribbean, and the like. And so really focusing on culturally tailoring materials and experience to those groups by working with them in community science partnership boards, which is what we do. I think that is a really important first step to addressing some of these barriers and challenges. We don't have to be, each of us doesn't have to be an expert in all things, and we don't have to do everything all at once. But we do need to know the populations that we are working with and how to partner with the community in order to best address those needs of those populations. The other thing I'm going to say in brief is the issue of expertise. I think I have felt worried in the last couple of years, especially since George Floyd and kind of recognition of the structural racism pandemic, that there has been such a rush and have different ethnoculturally diverse populations in studies that that has been such a focus that there hasn't been always a focus on having the right expertise in those studies. And there's been a real gap, I think, in thought leadership and expertise of frontline people and training to have people with appropriate cultural competence and expertise in the populations they're going to be working with in those studies. And I think that that's a problem that in some ways could eventually do more harm than good. And I think, big projects, clinical trials, organizations need to take their time and make sure they have the appropriate expertise, regardless of a person's background, in order to do the best possible job with the populations they want to understand and serve.
And I would say, in addition, the appropriate sort of cultural humility, right, and addressing our own implicit biases certainly come to
Absolutely.
play. So we do have some questions from the audience, and whoever from the panelists would like to jump to this one. So does it make sense to consider genetic differences in health outcomes, or should all differences and predispositions be considered a result of equity-related issues until proven otherwise?
Well, that's a great question. I'm happy to take a shot. I'm not a geneticist, but I mean, the reality is that we know most complex phenotypes, diseases, have some genetic contribution, right? Any kind of outcome we're interested in studying is influenced by our genes and by our environments. But as somebody who studies the environment, the thing I always emphasize about genes is that we can't change them, right? The genetic code we're born with is the genetic code we have. We certainly are learning more about gene expression and some of the more modifiable aspects of how that genetic code gets expressed. But ultimately, the DNA we're born with is the DNA we stay with. So the place where we have an opportunity to intervene is in those environmental factors, which is why, from an equity perspective, it's so important that our science remains focused on understanding what about those environments contributes to unequal outcomes, because our interventions inherently are going to focus on, those environmental pathways.
I would argue, Liliana, that probably the greatest lessons to be learned is in the context of epigenetics with the interaction of person and environment, where we can actually better understand the impact on fetal and early infancy in terms of the environments in which they're created and born. And I think that's where the action will be, at the intersection of person and environment. And it provides the greatest opportunity for actionable efforts and interventions.
Yep. I mean, anybody else?
I could chime in just for a moment. So we do know that with MS, there are certain genetic factors that do give you a higher chance of developing MS. There are those genetic components, and there are genetic differences even within the groups. If we compare Mexican Americans, Puerto Ricans, you do see those differences. And also genetic testing is important for certain rare diseases such as ALS, where certainly that identification at a very early time frame could mean the difference, all the difference in the world for that particular patient and the eventual outcome. So it is probably good to keep an eye on both the genetics and the environment. I think there's room for both in this area.
I'll also jump in just to also invite us to remember that when we're talking about genetics, we just have to be mindful and careful when we talk about genetics and race, right? Because we know that race is a sociocultural construct, right? And, you know, I think it's very easy at times with a lot of enthusiasm around genomics and genetics, which is obviously very important, that that we don't conflate the two, and that we are very mindful in the work that we do. And I really agree with much of what's been said here, that really looking more at epigenetics makes a lot of sense. And of course, these more exposomic factors as well.
Same here. I agree with as someone that works on both in research. Certainly, that is the main thing, is not to, you know, confuse or consider that, you know, biological aspect of race. But, you know, and obviously, I completely agree that focusing on the social cultural factors, you know, gives us way better, you know, considerations for interventions because they're modifiable. So one last question, and I don't know if we only have about a minute, but let's see if anybody can answer this. How can a syndemic, so this is intersecting epidemics framework, be applied to addressing CNS disparities in diverse populations? Anybody wants to take a shot at that one?
I can. I'll jump in. In a foolhardy way, I'll jump in. I gave a presentation about syndemics from the perspective of aging, you know, racism and you know, ethnocultural health inequities and intersectionality in terms of other aspects of identity as well. And to me, you know, I think Dr. McLaughlin, you spoke to the fact that, you know, what we're talking about here are complex disorders, complex CNS disorders that, you know, are going to have, you know, multivariate approaches to addressing them. And I think syndemics is just a way of thinking about these different systems or spheres of influence and where they intersect, where we can have these more complex interventions that are working on multiple levels, because that's what it's going to take, right?
Right. Well, thank you so much, and we made it to the hour. It was a pleasure to have each and one of you participate in the second part to this discussion, and I look forward to seeing further discussion via the website.
Thank you,
Thank
Dr.
you.
Maxwell.